Well, we might be a small group today. We'll see. I'm still waiting on Amber, but she can, when she joins, hopefully she can just jump in. Since we're a small group, we'll keep this as an informal, and if we can end early, we'll end early. Um, I wanted to hold space today to just talk a little bit about certainly any things you guys want to bring up, but one of the key topics that um, is just a recurring topic around integrated care in general, but particularly in FQHCs, is how do you measure stuff? What measures do you use and what metrics do you use both for not just for clinical outcomes but also program outcomes? And we've had various discussions over time in this group around those sorts of things. So I wanted to just start off by sort of asking you all before I just go in and talk about stuff we're thinking about in terms of coaching clinics and things like that. What are your members collecting? Like both in the category of clinical and operational, what are your members collecting and maybe like why they're collecting that stuff would be kind of a good place just to ground our conversation. So um, Mary, Amy, Taylor, um, anybody can just jump in and say, yeah, just what some things are. And Amy, I know you won't be on camera. Sorry about that. We had a run of illness in our family last week. Whatever's going around is not fun. So I hope you feel better. Feel free to type text in the chat, um, anything that you see in Pennsylvania. So yeah, what are people measuring? What metrics are people using?
I can say what I see. I think on the clinical side, a lot of it are the UDS metrics that are required by HRSA. So like depression and follow-up plan or depression remission. I think there's some new substance use disorder screening metrics that just came out for this UDS year, as well as all the other HRSA required metrics. And then I think on the more like program evaluation side, or program outcome, certainly I see a lot of places tracking population penetration or tracking BHC involvement with a certain group of folks with a particular chronic health issue, or positive pregnancy or postpartum, um, warm handoffs, like which percentage of the visits are warm handoffs versus follow-ups or scheduled. Those are
Yeah,
kind of off the top of my head.
cool. And Amy said same, focusing on the MOUD UDS measure as well. So it's
Yeah,
been a big topic.
that's been definitely a topic of our like behavioral health work groups. And also, I mean, obviously, Mary Carol and I are in the same state, but there really seems to be a huge focus on the maternal health piece and data collection around that. And um, that is just something that I feel like our health centers are really focused on, but also the MOUD. But again, we have the same clientele. So yeah.
And when you say the MOUD metric measures, which one do you see people focusing on here? Because I'm looking at them right now.
Let me see if I can pull it up.
So there's a percentage of members 18 years of older who receive prescription opioids at high doses. There's the multiple provider one.
The multiple provider one, I think.
Okay.
But yes, it's the multiple provider one because the issue for some of our health centers was, oh my gosh, we're not providing MOUD services. And what does that look like? And thankfully, I feel like in Pennsylvania, a, a lot of health centers have began to offer those services, but we still have some that just don't and some that I don't think won't. So it's creating those strong referral relationships that we were really focused on talking about.
Yeah. Yeah. Okay.
I can hop in. As you already know, same days are a big issue, so I'm not exactly sure what they're tracking for measures there, but I know when we did our survey and data, a lot of them were still tracking same day services on claims, just not obviously getting paid for it. So we have some of that data in our behavioral health report. Something else unique to us is the ACEs screening. I know a bit, not full integration there, but a lot of efforts on what that workflow looks like for ACEs screening and getting folks connected to services through that line. And California spent a lot of money, and we currently have a grant right now working on how ACEs can integrate with CalAIM services, so ECM, community support, some of those other higher levels of care, and improving those workflows. But this question just makes me think for the next round of our behavioral health survey, something we can potentially add to our behavioral health integration section beyond what we asked this year regarding same day and then co-located versus full integration, because I don't think it's something we've talked about with our members in depth, at least since I've been in this role.
Yeah. Yeah, that's great. Yeah, and California is one of the only states that I know of that's doing ACEs screening, and having anything tied to ACEs screening, which is a little bit disappointing, frankly, after all of that work in the early 2000s around ACEs. I know at my clinic, I started us collecting ACEs stuff, but then it just sort of lost steam because there wasn't any support for it. There wasn't any driver like a HEDIS measure that we could connect to it terribly well. So California is definitely unique in that respect.
Yes, and we're funded by the ACEs Aware initiative right now, and so we're pushing it as a how can you integrate it with other services, and also in this state of the world get that additional $29 reimbursement outside of PPS for those screenings as an additional incentive for that workflow, and then how can you connect that with the broader ECM, community supports, new certified wellness coaches, sort of braiding these additional opportunities that are coming down the pike. So we'll be doing some trainings and have some resources within the next 6 to 8 months that happy to share once they're created. But they're in the works of sort of, we're calling them case studies, but that's a loose term, more of 1-2 pagers kind of example panel sorts of how the health centers are, who are doing it well, or those who aren't, what are the challenges they've run into when trying to implement it.
Yeah, that's great. I look forward to seeing that, and certainly will disseminate to everybody. Amber, I'm going to get you in here in a second.
No
Just
problem.
a thought as we talk a little bit about this. We're in the midst of a Pew Charitable Trust grant, I guess. They're paying us to put together these case studies on polysubstance use in FQHCs. And so we've gone out, done 5 site visits, or we'll be completing site visits here real soon. And then we're producing reports on that as well. And that's going to be freely available to everybody once it's done. But one of the things that I think is really interesting about that work, and that cued me to what you were talking about, Taylor, about how you're trying to connect the ACEs into some of the other work going on, is that clearly what we're finding is that the earlier MOUD work was foundationally important to help support the polysubstance use work that health centers began to do more after that whole movement, essentially. And that MOUD work for a lot of the most successful health centers that we're talking to was built off of the integrated care work. So in essence, I think a key learning is that if you're going to build in something else, whether it's ACEs, whether it is polysubstance use work or anything else, you definitely want to connect it to things that you're already doing and doing well, and that you can layer basically on these new whether they're interventions or programs, if you layer them on top of existing work and existing transformation efforts, that's the main thing, existing transformation efforts, so that each one is not another transformation effort, or at least not a completely different transformation effort. That seems to be the way that these health centers have been able to successfully build these in. So anybody who did MOUD work, seems like they built it off of integrated care because they'd already had a decade or so of work there. Then they built the MOUD work, and then on top of that, they started getting better at that. Then they built in the polysubstance work, so they're better with alcohol, they're better with stimulants, etc. Right? They had staff trained, they had philosophy in place. So I think tying in some of the ACEs work to some of those other movements also in California makes a lot of sense. So anyway, just my 2 cents. All right, I'm going to pause our conversation. We're going to come back to this metrics conversation, but I want to make sure that we give Amber some time here. Amber, we're a small group today.
That's okay.
But hopefully we can help Amber with some super duper important research. Like, this is so super cool what Amber's doing in terms of really trying to detail the impact that FQHCs have in their states and regions, and tell the story of what to this point I think has been undocumented. Right? It's like it's a story that we know because we live and breathe FQHCs, but it's not been told. And Amber's putting the research behind telling that story. So she needs some of our help. So we're going to give her a few minutes here to talk about the research and some of the specific help we might be able to give her.
And hi, Taylor and Amy, who I know I've connected with through this process. So thanks for your help already. Since it's a small group, and then maybe it looks like Mary Carol and Kimberly, maybe you guys can tell me what states you represent.
So I'm the Director of Behavioral Health Integration at the Health Federation of Philadelphia. And so I'm not technically a PCA. I'm in the southeastern Pennsylvania area, supporting our local group of integrated care practices.
Great.
Many
also work with Amy
of
often.
which are QHCs.
Yeah. Most of them are. Yep.
Great to meet you. And then there's a Kimberly on.
That's just a note taking.
It's just a note taker. Yeah. Okay.
Yeah, and
all
then
right.
Also treat this as if other people are listening, because the recording goes out to the group.
Oh, okay. So then I should do the whole presentation. I know both Amy and Taylor are familiar with this, but let me just pop this up since you're going to be sending it out to the whole group, and hopefully we're doing one last push through the end of the year to try to get responses from health centers. So am I able to share on here?
I hope so.
So, okay.
Yep.
All right. So I'm here to talk to you guys about the BeNCH study. Many of you already know about this. It's the Benchmarking Behavioral Health Integration in Community Health Centers. It's a 3-institution study led out of the University of Washington, and we're working with investigators from UNC and University of South Carolina. So we all know that our health system doesn't work for patients, that of the 60 million or so adults that have a mental illness, that only about half per year get any kind of treatment for their condition. And then there's about 8 million children and adolescents who also, similar numbers, don't get any services for their mental health condition, much lower rates in the substance use world. We also know that there's, pretty good clinical trial evidence for both of these models, the collaborative care model and the PCBH model. There was a huge Cochrane review of over 90 randomized controlled trials that shows collaborative care improves depression and anxiety, symptomatology, guideline concordant medication use, quality of life. There's less rigorous data for the PCBH model, which most health centers are implementing, but we do see some signal that it improves screening and reduces wait time, so improves access in general to timely care. We also know that since the Affordable Care Act, that there's been a lot of, federal pushes to try to expand behavioral health services that have led to a dramatic growth of behavioral health services in health centers. So this was stuff that we did using UDS data linked to global burden of disease data, which maps the prevalence of behavioral health diseases. And what we were able to show is that health centers are actually providing a greater proportion of Americans' behavioral health care over the last 15 years. So we're treating more of the population with behavioral health disorders. But even though most health centers are rapidly increasing their service offerings, many with integrated models, there's really limited real world evidence on how that is benefiting, especially state Medicaid programs, which I think is a more important than ever. So the goal here is really to demonstrate that value that you guys are already creating. Now, so we have this 5-year NIMH funded study with this overarching goal that we are taking this policy lens to demonstrate the value that health centers create for state Medicaid programs through expanded behavioral health service delivery and offerings, and especially novel models of integrated care. And we're going to be studying a lot of different outcomes like access to care, specific behavioral health outcomes, equity, and then hopefully some spending outcomes as well. Now, since we started this study, the landscape has completely changed, so I want to mention this. This has made it exceptionally difficult to essentially field a survey to health centers right now with all the chaos coming out of the federal government. But if I can make one plug, demonstrating how these actually save states money, these kind of services can save states money and can improve the health of their patients in the long run, will hopefully, in this setting where the federal government is going to make cost sharing much more difficult for states, will hopefully help preserve some of the funding for these kinds of services in health centers. So I think it is more important than ever that we kind of create this data. So these are the objectives of the larger study. It's a big study. We're still in this first part, which is to assess the national landscape of integrated behavioral health and community health centers. And we're doing that through a brief survey that is site specific. This has been hard, as most surveys, as we expected it to be in health centers. And so any assistance that PCAs can give us, there's multiple ways that you guys can help us connect with health center leaders. And many states have already been helping us through these various avenues. But we would appreciate targeted outreach, sending this through newsletters, introductions with key people leading health centers, to try to get a better response rate on the national survey. And a lot of this work, now I will say, there's a lot of claims-based work. We're going to have 100% national Medicaid claims from 2018 through 2025. So we will be able to do a ton just with claims data, looking at behavioral health service delivery and its value in terms of patient outcomes, and even the kind of state policies that may lead to greater behavioral health service delivery. But if we want to assess integration, you got to do that through these tools. That is what we're fielding in the survey. And so a lot of the goals of this work, if you really want to say something about integration, we need to have a good nationally representative sample of health centers who are participating. And we're doing pretty good so far. I think we have 320 responses back so far. And for the most part, those health centers look like the national, the nation when we compare them to non-responders in the UDS data. That being said, we are shooting a little bit under for our Southwest states, kind of the mountain states, and definitely smaller rural FQHCs, which we expected. All right, so a little bit about the survey. It is a survey of delivery sites, not of the FQHC organization. Our inclusion criteria are brick and mortar primary care sites. So the site should be set up to deliver primary care. We're not doing like rehab sites, specialty behavioral health sites that might be integrating primary care. If the site is dedicated to a very unique population and doesn't serve the general public, then that is probably out as well, such as a site that's running in a homeless shelter. The site must be open more or less for 4 full days a week. So a full-time clinic is what we're looking for. And this is really, really key. It does not need to have an embedded behavioral health staff or be implementing an integrated model to participate. And that is because all health centers deliver behavioral health care. And if you look at these instruments, which I'll show you in a sec, many of the activities are par and parcel, like screening for behavioral health disorders, the extent to which when you have to refer out for care, you coordinate that care. So these are kind of like medical home elements too that factor into these integrated behavioral health assessments. All right, so the survey, the main crux of the survey are these two instruments, which you may be familiar with. One is the integrated practice assessment tool, widely used, probably not the best instrument in the grand scheme of things. It gives between 2 and 4 questions using a lot of skip logic that are just yes, no statements about the practice. The main instrument we use is the practice integration profile, and this is the only validated instrument out there. It was created by a team of psychologists from UMass. And this looks at several different domains like workspace and integration, patient identification, clinical services, etc. And ultimately, both will give you some level or degree of integration. The IPAT gives you a level 1 to 6 following the SAMHSA framework, and then the PIP will give you a total integration score across all these domains on a scale of 1 to 100. All right. Other details about this, the survey shouldn't take longer than 20 minutes to complete. There is a $50 gift card that will go to either the respondent, or in many health centers, they're actually combining the incentives across the sites that they will fill out surveys for, and then having us deliver that as a single payment, and they'll use it to buy lunch or something else for their staff. So for example, if a site runs if a health center runs 6 primary care sites that are eligible, they can submit 6 surveys for $50 each. We have these 2 instruments. Like I mentioned, there's 10 extra questions. I would love to share those sometime, especially the ones looking at financial strain on these services, I think are going to be important for us going forward. But we have a handful of other questions about how sustainable the services are, what types of behavioral health providers are employed. Have you had vacancies in the past year? Have you had to cut back since COVID for any reason, and why? Do you train behavioral health professionals? Because that often brings in additional money. So does your health center run community mental health or other specialty behavioral health sites? None of this requires you to pull any data. The PIP looks, when you look at the instrument, it looks like it's a lot, but in reality, it's asking a question like, we do collaborative care plans. And then it's asking you, of the patients that have a behavioral health disorder, what proportion get a collaborative care plan, 0 to 100%? So it's pretty intuitive, and it's meant to be like, oh, we're about 20%, we're about 80%. That's how you're supposed to fill this out. Okay, who completes it? So the PIP and the IPAT should be completed by a senior clinician who knows that clinical site well and can comment on the overall patient population, not just their panel. So like a site medical director, associate medical director, a behavioral health manager could be the point person per site. We recommend that you get collaborative input. We know from preliminary data that when behavioral health fills out these instruments, they have sort of different responses than primary care because they're seeing different denominator populations. So what makes most sense is to try to get your behavioral health person, if you have one, and a primary care person, at least 2 individuals from a care team, to sit down, pop open the survey and say, where do we rank? Da, 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 da. We offer the PDFs of these surveys as well. And so you can do that collaborative input asynchronously if that works better for your organization, and then just have someone kind of adjudicate or combine the responses. We will give you benchmark data back. So we will benchmark your integration scores and data against other health centers in your region, and then nationally of the same size and urbanicity. And hopefully that data is useful for grant making and strategic planning for you immediately. what else are we going to do? So once we can get those reports out to you, the next thing is we're going to link in these integration scores to a bunch of different data sets, but the main data set is national Medicaid claims. And so we can actually attribute patients to sites of care and look at their outcomes as a function of the level of integration or the level of behavioral health services they're delivering that are being delivered at that site. We will also look upstream and kind of try to get at some of the structural characteristics, organizational characteristics, and ultimately state policy factors that may be leading to more or less behavioral health integration. And once we get those Medicaid outcomes, we're happy to feed them back to organizations or PCAs as well. I think we're doing this survey. We will create the claims-based measure of integrated care, but there's a lot of opportunity for our team to continue to interact with the PCAs in particular, because I think, especially as we start working with claims data, there's a lot we can do in terms of messaging that value and from kind of like an overall policy stance where we'll have the complete view of behavioral health services that are being delivered in a state with the claims data, not just the participating organizations. So I would love to continue to have open lines of communication with you all for the ongoing duration of this study. All right. And then in terms of outcomes, we will look at the claims-based outcomes that are in the mandatory core behavioral health measure set. It's the same measures for 2025. So most of these, let's say administrative, are claims-based. And then we'll also be looking at things like continuity of care and then all cause and behavioral health ED use and hospitalization. So we'll be able to have a pretty comprehensive picture of the kinds of outcomes that could result from these models in the real world. All right, that's it. That's all I had. This is how you can contact us. The BeNCH study at uw.edu is our study email. If you want to reach out to us, we can send you a link to my calendar if you need to speak with me more about the study, and we can have, you can self-schedule. There's also an open source link on the website now for the survey. It's better if people understand what they're supposed to do and how they're supposed to complete this, but actually all the information is up there. So feasibly, you can send out the open source link to your partners now, and they can just hopefully fill it out. All right, that's all I have.
Awesome. Thank you, Amber. So do you prefer us to send people to you specifically versus the open link, or does it not matter at this point?
It doesn't really matter, whatever works for people. What would need to be communicated that if a health center just wants to go through the open source link, they should read those instructions carefully, right? They should have a clear understanding that this is site specific, what sites should be included, especially with the larger health centers. They're not including all their eligible sites. It's too burdensome. So they often select a subset that, has strategic purpose or whatever, or maybe they're planning to ramp up, or maybe represents kind of the breadth of patient populations in care. So there's different ways, and I'm happy to have a convo with anybody and figure out how, which sites and who would be the best person and how they would operationalize the survey. But we have gotten some people filling them out through the open source link. So the key is if you send that around, just make sure that your members really understand what they're supposed to do and who's supposed to be filling it out, and especially that collaborative input aspect.
Yeah.
All of that information, like inclusion and exclusion criteria, is also on the website, as well as ways to reach out to us. And I believe we should even have my Calendly calendar up there so they can just self-schedule if they have questions.
Awesome. And the other question I have for you is do you give me permission to take portions of your presentation, put it up on our socials? Is
Yeah.
that okay?
And actually, I can't attend the CFHA conference, but Brianna from our team will be. So I think we're going to print some cards or something. So we can either, I have a teaser slide where you could just throw this up with the QR code somewhere if you have that, or I can put these out somewhere. So whatever would work would be great.
Yeah. Offline, you can tell me what you need and I'll tell you what we can do, something by registration or,
Cool.
pre-plenary slide. We have rotating slides while the plenaries are getting going. So there's lots of options. Yeah.
Great.
Awesome.
I really appreciate everybody's help, Amy and Taylor, for your help already. Okay, bye,
Thanks,
folks.
Amber. So, all right. Thanks for listening to that, even though you had already had some orientation to that. Hopefully it does inspire you. It does help me to kind of refresh, like, yeah, I can probably do a little bit more outreach here. See if I can hit up some of my friends. So talking about metrics, Amber actually referenced two global metrics, which are the level of integration metrics. So I wanted to ask about that specifically as part of our conversation about metrics. In the health centers that you're interfacing with, are folks, well, maybe a good way to say is what % of the sites that you interact with have done some sort of self-evaluation, either using any of those tools, or I suppose they could have used some of the other tools. Like, is it 10%? I know it's not 100%, but is it, what percent have you think probably done some form of self-evaluation like that? Go ahead, Mary.
So I can say for the Philadelphia area, it's quite high. It's probably like 85, 90%. And part of that's because actually I was just working on this morning. Our health federation, we partner with our behavioral health managed care organization. And there is an annual site-based self-reflection based on the iPad tool, but it's not the specific questions like yes, no. It's more of a reflective conversation. And so once a year, Health Federation facilitates meetings for across sites. I think last year there were like 34 sites that participated. And it's an hour, it's a behavioral health consultant, a medical provider, and an operations person. And then we use the iPad as the guide. And then folks get we take notes and summarize it and send it back to the sites, as well as then we do like de-identified summary that goes to our primary funder.
Yeah, that's great. And that's I think one of the ways that I sort of envision PCAs potentially playing a role in the future, doing a little bit of that kind of organizing work around it, right? Because it's hard for individual sites who are unfamiliar with the tools to sort of organize themselves around the work. It's not actually that hard to actually organize it because the tools are not that complicated, but it takes a certain amount of like startup energy and some familiarity with the tool. And it sounds like because of the Health Federation, which in a sense operates very much like a PCA from a sort of coordinating standpoint, seems like I'm guessing that's really the impetus, right? It's you guys at the Health Federation really cueing the health centers that they should be doing this.
Yeah, and I think we have the relationships with them to foster that. And I think it's a positive experience for people. Of course, I want to believe that, but I think that it gives folks a chance. The pace is so busy, so it really is this moment to pause and connect with each other and reflect with each other.
And you really get good information. I've done these with health centers. It's always been very, very positive and helpful. Like you actually get some really good information about like what we're doing well at, where we're actually seeing the same things or seeing different things in terms of our operations. And then because you're trying to get a cross section of your staff working to fill these out, you are building relationship necessarily. So I agree. I think once people understand what it is and go through the process, they're good. It's just really getting people to do it, which is a lot about metrics, right? I mean, that's sort of a theme that I want to call out here. It's like a lot of metrics is motivating people to get to the doing part and make meaning out of those metrics. And these sort of level of integration metrics are one of the ones that usually gets off the wayside because obviously we're not getting paid for it. We're not getting any, typical payment usually for it. Although I think going forward, that would be one thing we would recommend actually is part of contracts because it's part of what you're providing, an integrated care team. So how good is your integrated care team functioning, right? That's what you're saying with these tools. Amy,
Yeah.
yeah,
Oh,
what I was
I
going to
was
ask
just
you. Yeah.
gonna, say, I know for me, I'm so grateful for the Health Federation doing all of this work because as a state that's not a PCA and HCCN like combined, even though we work so closely together. It's so great that our health centers are getting this opportunity because we don't have that capacity in our PCA. Like we don't have a data person. So it's so nice that our health centers are able to get this like through the Health Federation. So I just wanted to say that.
So I'm assuming that means that outside of Philadelphia, most of the health centers are not kind of doing their self-assessments.
It's so interesting because at our one of our like last in-person meetings, just the strides that the Philly health centers are in comparison to a lot of the other health centers is it's crazy. I mean, of course we do have because there are health centers that are in Philadelphia that are members of the Health Federation. So that's great because they have access to that too. So I would say it's growing throughout the rest of the state, but it's definitely nowhere near what like the Philadelphia health centers are.
Right. Yeah.
So I'm very thankful for that relationship because it would just be non-existent without the Health Federation.
Yeah, it speaks to the importance of a network like the Health Federation in a state because they're focused on, all right, as a PCA, you guys are focused on a lot of things. You have to be
Yeah.
serving your members across a lot of areas. This particular network is just focused, like Mary's job is just focused on supporting the member health centers on integrated care technical assistance. So
Yeah.
that makes a big difference. Like it's supposed to make a big difference. It really does, right? Yeah.
Yeah. And fostering, I think, for our organizations, like that strong relationship is so important to me because it just benefits our health centers so much more.
Mhm.
Um,
Yeah.
so yeah.
Yeah. And I think one of the things I wanted to kind of provide as a theme here before we let you chime in, Taylor, is just I think these sort of um, I think you can think of these assessments as discrete interventions. And so when you're thinking of an intervention, you're trying to think about the ROI. What's the ROI on a particular intervention or particular strategy that we're trying to deploy? And I think that encouraging your member health centers to participate in self-evaluation exercises with these tools is well worth the ROI because you're going to touch on a number of the different pieces that health centers might be struggling with, might be able to more specifically identify areas that they can target for growth and improvement. And if you get enough of them in your state doing this, I think that can actually build some momentum towards people then working together a little bit across health centers to help each other, which is essentially a lot of what the Health Federation network does, right? People start getting to know each other, they support each other, they shadow each other, they, do some education together. So, IPAT, PIP, it's well worth it. And if, for example, what if I could train all of the PCAs in the country and I had to like pick a top list of like 3 things I could train them on, things that I think would have the biggest ROI, this would be in the top 3 for sure. I would just train you guys on how to administer and facilitate an IPAT or PIP type meeting and evaluation process. It's that important. So Taylor?
I would say I don't think most of our health centers, unless they've participated in the BeNCH study, have completed the assessment. We did a big push with Dr. Sabbatini to come to our behavioral health group earlier this year. So hopefully we got some participation there, but we have not done any specific work on those assessments, particularly as far as I would hope, I'm going to assume here, but when they took our behavioral health survey at the end of last year, in order to address some of the behavioral health integration questions we asked, I would hope that they at least had some sort of conversation or reflection on what it was currently looking like in order to answer those questions, although not a formal assessment. We had about, I think it was 60 responses, give or take. And so that's a small number comparatively to the number of health centers we have here in California. So I would say under 5%, give or take, based on those response rates. And again, not even a formal assessment. It was very brief as far as models and then what it looked like integrated both from the specialty or drug medic health side and then just non-specialty behavioral health as well.
Yeah. And what would you say, Taylor, is maybe a barrier to people using these tools? Is it just lack of familiarity? Is it time?
My guess would be the big hangup is if we can't bill for same day, why do an assessment if we then can't get reimbursement for some of this, especially in today's environment with so much uncertainty? I think that's the big hangup in moving forward in integration in the state in general across the board for health centers. So I think it would probably be that, as well as I think our trifurcated system with specialty and DMC and all of those pieces just make it a lot harder to truly do what the integrated piece looks like. And so I think there's a lot of barriers to that contracting. And so I think those barriers then contribute to why do an assessment if we can't fix these other barriers, at least at the moment. I think the ones who have probably done it are those who have those specialty contracts, who are CCBHCs, who are already expanding beyond the non-specialty behavioral health. And there's those who have those contracts and have done that, but we hear a lot barriers with contracting, barriers with ECM and reporting requirements, like even those who have stepped out to try those new things to create more holistic care, there's still barriers, whether it be in payment or just workflows and reporting.
Mm-hmm. Mm-hmm. Yeah. 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 That makes sense, right? It's, and as much as I would want to champion and say, well, you could at least get a baseline, right? That's not very satisfying from the other side of things. I can totally relate to that. Yeah.
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 So I think there's ones that are interested. I think there's just a lot of barriers stacked
Sure.
against them. So there's those that have gotten creative, or there's those where like, yeah, we would love to do it. It's just not top priority right now for them.
Yeah. Yeah. Well, if you haven't looked at any of the tools lately or are familiar with them, I do encourage you to take a look at them. They're easily available online. So if you just do Google iPad or Google the PIP, make sure you go to for the PIP. Make sure you go to the UMass site. At least until recently, there were older versions of the PIP that were on other sites. The most updated is on the UMass site. Take a look at them, look at the questions, look at the format and structure. Might give you just good familiarity with them. And then you can adapt just like you guys did, Taylor, it seems like, with just asking some questions, because you don't have to do the whole tool necessarily to be helpful. You can just be thinking about some questions around that that might help health centers just understand themselves a little bit better in terms of what they're accomplishing, even with the constraints that you guys have in the state. And CPCA just became an ACCN. Okay. All right. That's hopefully going to be a helpful step as you start sharing some better data. So, all right. So, that's sort of when we talk about our metrics conversation, right? So I frame it as there's these operational metrics. And so level of integration is one of those operational metrics that we encourage health centers to be doing self-evaluation on, because that helps you do things like plan strategically for future growth changes that you need to do. If you figure out through your self-assessment, hey, we thought we were screening well, but actually we're not. Or, yeah, we thought that we were, collaborating more effectively together in the medical record, but we're not. We're not putting care plans together. It gives you very strategic ways to grow your work, right, on a programmatic level. And Mary actually referenced some other operational metrics. And again, I've talked about those before in other sessions with some of the tools that we use. But those metrics include things like penetration rates, right? So like that's something that no matter what model of care at an FQHC, you should be tracking your penetration rates, which is basically a denominator of your total number of patients seen in a given time frame by the whole clinic, and then a numerator of all the patients seen by your behavioral health services, right? And you can obviously break that down into specific services, whether you have consulting psychiatry or PCBH, et cetera. And so things like a population penetration metric become absolutely crucial. Things like what length of visits you're having. Usually I recommend just using the codes as the way to track that. So 90832 is going to be like a 30-ish minute type length. 90834 is going to be a plus 36 minute length, right? And so tracking that code utilization becomes a proxy for things like how you're adhering to a model. Like if your model is PCBH, most of your visits should be 90832s, not 90834s or any of the other variants. If you are in a specialty only model, which a lot of your centers, Taylor, would be probably in California, you're probably going to have a lot more 90834s as your predominant code. But tracking that gives you a sense of utilization. And obviously the usual other metrics like time to third next available, no-shows, things like that are programmatic metrics that you should be tracking. Now, as much as we might think health centers are actively tracking those effectively, in my experience, a lot of FQHCs specific to their behavioral health work are not tracking those. And if they are tracking them, it's a person that's tracking them, but it's not being communicated effectively. It's not actually being used in strategic planning. So the other thing that I encourage people to do is just to not feel bad about that, not like react with a sense of shame, but actually to do a little bit of reflective work on why. What is it about our organization that we either don't track these things or that somebody in our organization is tracking them, but it never really gets down to a place where people are using that to inform either program changes or solving some workflow problems, right? That requires actually reflective work. And by reflective work, that means like asking the hard questions. Like, okay, so this person gets these metrics, but it never really gets over here. Interviewing those folks and saying, hey, what are the ways that you try to communicate this? Why does that not work? What obstacles do you have in communicating these or collecting the data? Sometimes it's just a data collection issue. Sometimes it's a data lag issue, right? You collect it, but it's 6 months late, right? So that's a key conversation to have because I do not see health centers collecting these sorts of metrics for behavioral health on a regular basis. And that leads to unfortunate conversations, which I'm sure you all have heard from your behavioral health staff, namely productivity conversations that typically come from administration. So administration will pressure behavioral health and say, hey, you guys are not seeing enough patients in order to get us into the black. Which is an interesting question because in integrated care, typically all of the power for like basically the revenue, the referral source are the medical teams or the care teams essentially, right? So like the behavioral health staff are not like doing marketing to like get new patients to come in there and get on their schedules, right? But if they have, for example, if you had a metric that showed your time to third next available is 12 weeks, and then along with that, you had a show rate that was hovering around 50%. right? Those metrics would help you understand some of what's happening, right? It would tell you, hey, yeah, I may look like I'm busy, but actually only 50% of my patients show. And that's because I'm booked out all the way, 12 weeks out, and no-show rates increase with the time, down the road. So that becomes a way to have a conversation with administration and say, hey, we need some support for making some changes here. They may be scheduling changes. It may be conversations with our care teams, where instead of asking us as behavioral professionals why we're not seeing that many people, we have to talk to the care team and say, hey, why are you maybe not referring? What are the referral barriers to getting people seen, right? So that's the power of reflection around metrics, is where you're asking, the way I would put it is you want to ask curious questions, not shame-based questions, not like questions that are meant to punish people, which is unfortunately the way metrics are often kind of couched. It's like, no, we just want to ask curious questions about what these numbers say about us, why we're using them or not using them effectively. I know we're here at the top of the hour, but the last category here, of course, is clinical metrics. And so I wanted to show you a quick tool that we developed. See if I can pull it up here real quick. Oh, there you are. All right, you'll recognize this as ChatGPT. So we developed a couple of tools that are free to use. They're just up there on the ChatGPT store. You can search for them very, very easily in the GPT store. And so one is a very general tool. And this tool is a tool that you can use yourself or send it to your directors, even your CMOs. Anybody at a health center can just go in there and ask just about any question related to integrated care. We've trained the tool, we've loaded it up with some of our key documents, and people can go in there and just ask questions and maybe brainstorm or troubleshoot a particular area. So for example, this might be a good tool to use if you're looking at trying to think about some of these larger issues around metrics and things like that. So you could ask it something like, even like, hey, I'm trying to come up with a series of metrics that look at our program's functioning, for example, and we run PCBH as a model. It does a decent enough job within good parameters to give you some really good results. So we've had some good feedback on this tool. As with all tools, of course, AI tools, not perfect, but it's actually really pretty decent. Then the other tool related to our conversation today is this tool. I'm not sure what happened to the logo there, but this tool that's specific to outcome tools. So if your health centers are struggling with like picking or working with particular clinical outcome measures, this is the tool you want to direct them to. We call it sort of like a measurement repository tool because we loaded it up with the data for a bunch of tools, literal tools, and their research data behind those tools. So everything from the PHQ-9 to PROMIS to a bunch of substance use measures and trauma measures, etc. It's in there. And so it is trained to know these tools and to help you think about how to use them effectively, how to integrate them into a clinical outcomes process. So I've asked it questions like, help me think about how I might use this tool in my patient care, right? So that'd be like an individual, but you could do it as for a clinic as well. So these tools are freely available. If you search for them on the ChatGPT store, they're there for you to use. I will also send them out in an email. I'll send out an email, just the links to the tools themselves, and please feel free to share widely. All right, we're at the top of the hour. Thank you for spending some time today. Look forward to seeing you guys at a future meeting.